Hello everyone, welcome to today's class. Today we are going to start cardiology, and the first topic that we are going to discuss is acute coronary syndrome. So what is acute coronary syndrome? Acute coronary syndrome is basically three diseases comes under this term, acute coronary syndrome, and those three are non-ST elevation MI, ST elevation MI, and unstable angina. The presenting feature for all three of them will be same. ST elevation MI, non-ST elevation MI, and unstable angina, and they all will be presented with same sign and symptoms such as chest pain, central or epigastric chest pain that radiates to arms, shoulders, neck, or jaw. So the main presenting complaint will be chest pain. Along with chest pain, the patient can also have other symptoms such as increased sweating due to increased sympathetic activity, nausea and vomiting, dyspnea, fatigue, or palpitation as well. So the main presenting complaint for acute coronary syndrome is central chest pain, which may be described as substernal pressure, squeezing, or aching, or burning, or sharp pain. So the nature of pain will be squeezing, or burning, or sharp pain that is in the central chest or epigastric area, and that is radiating towards left arm or neck. Along with pain, the patient may also have diaphoresis, which is increased sweating that is caused by increased sympathetic activity during an MI. So if a patient presents to you with these silent symptoms, the first thing that you will do is you will perform an ECG to see if it's an ST elevation MI or non-ST elevation MI or unstable angina. So the first thing or the most important initial step in the management of a patient who present to you with central chest pain that radiates to left arm and neck is to do a 12 lead ECG. And after ECG, if there is elevation, ST elevation in the ECG, then it will be ST elevation MI. And if there are no ST elevation, then it can either be non-ST elevation MI or it can be unstable angina. How we are going to differentiate between non-ST elevation MI and unstable angina? We are going to differentiate. Now, unstable angina is basically ischemia which is not severe enough to produce any myocardial damage. So after a 12 lead ECG, we will send cardiac enzymes such as troponin, and on the basis of the result of the troponin, we will decide about if it's non-ST elevation MI or unstable angina. So after doing 12 lead ECG, there are no ST elevation in ECG. The second step is to send cardiac enzymes such as troponin. And if troponin is positive, then it's positive troponin mean there is myocardial cells injury has occurred. So it's non-ST elevation MI. And if troponin is negative, then it's unstable angina. So this is how
Please
we.
repeat it again.
Yes, I'll repeat it.
If troponin positive, this I didn't get it.
If troponin is positive, it means myocardial cell injury has occurred. Troponin is an enzyme which is present in the myocardial cells. So if injury or death of myocardial cells occurs, then when the myocardial cells die, they release this enzyme in the blood. So positive troponin means the enzyme is released in the blood by the dying cells of the myocardium. So it is a myocardial infarction. And if troponin T is negative, then it means this is only ischemia and no myocardial cell injury or necrosis has occurred. So it will be unstable angina. Is it clear now?
Sir, troponin maybe it can also become positive in STEMI also, right? Both
Uh, Anything that has myocardial infarction
damage.
in its name,
Mhm.
anything that has myocardial infarction in its name, such as ST elevation MI or non-ST elevation MI, troponin is positive. Troponin will be positive in every MI. Either it is non-ST elevation MI or it is ST elevation MI.
Okay, sir.
So acute coronary syndrome consists of three diseases. One is ST elevation MI, other is non-ST elevation MI, and unstable angina. To differentiate between ST elevation MI and non-ST elevation MI, we require an ECG. So the initial step, the most appropriate initial step in the management of a patient who present to you with a central chest pain is a 12 lead ECG. And the next step is to send troponin enzymes or cardiac enzymes. And on the basis of the result of cardiac enzyme, we can decide if it's non-ST elevation MI or unstable angina. Now, this was about the diagnosis of acute coronary syndrome, ST elevation MI, and non-ST elevation MI and unstable angina. Now, the management of all these three conditions, the management is almost same. There is only slight difference between the management of these three conditions. First, we will discuss the management of ST elevation MI. The patient who presented to us with a central chest pain and ECG shows ST elevation. How we are going to manage such kind of patients? First of all, as a patient presented to us with the central chest pain, so we'll give strong painkiller such as IV morphine to relieve his pain. Along with morphine, oxygen will also be given. Oxygen will be given to the patients whose saturation is less than 94. So if a patient present to you with ST elevation MI and his saturation is above 94, such as 95, 96, or 97, then there's no need to give oxygen. According to NICE guidelines, oxygen will only be given to the patient whose saturation is less than 94. Nitrates are also given so that coronary vasodilation can occur and the patient who's having pain due to ischemia can be relieved. Antiplatelets such as aspirin 300 milligram will also be given. So a short mnemonic for the management of ST elevation MI is MONA, morphine, oxygen, nitrates, and aspirin 300 milligram. Along with antiplatelets, we need we also need to give an anticoagulant such as heparin. Heparin can be given as an unfractionated heparin or low molecular weight heparin, such as enoxaparin or fondaparinux. So this initial management is same for ST elevation MI, unstable angina, and non-ST elevation MI. Initial management consisting of morphine, oxygen, nitrates, and aspirin 300 milligram plus heparin. This will be same in all three cases. Now, the definitive management of ST elevation MI, if the patient presents within 12 hours of the onset of the symptoms, after all this management, if the patient is presented to you within 12 hours of the onset of the symptoms and PCI is available at the hospital, then primary PCI is the gold standard treatment for ST elevation MI. For PCI, what is PCI? PCI is basically percutaneous coronary intervention in which a catheter is inserted through radial artery or femoral artery, and the blocked coronary arteries are opened or dilated through a stent. So after initial management in case of ST elevation MI, the definitive management is PCI or primary PCI. If the patient present to you within 12 hours within the onset, 12 hours of the onset of the symptoms, and if PCI is not available and if PCI cannot be done, then thrombolysis is done. Antithrombolytic, so thrombolysis is done through altiplase. Two drugs, two drugs can be used for thrombolysis. One is altiplase and another is streptokinase. If the patient present to you within 12 hours of the onset of the symptoms, primary PCI is gold standard. If primary PCI or PCI is not available, then altiplase or streptokinase. Altiplase is preferred over streptokinase because of lesser side effects and because it is safe. So this was all about the management of ST elevation MI. Now the management of non-ST elevation MI or unstable angina. Initial management will be same. Initial management such as morphine, oxygen if the patient saturation is less than 94, nitrates and aspirin 300 milligram plus low molecular weight heparin such as enoxaparin or deltaprin or fondaparinux. Any of them can be given. There is no role of primary PCI within 12 hours of the onset of the symptoms in the management of non-ST elevation MI and unstable angina. Remember that low molecular weight heparin or fondaparinux should be offered to the patient who present to you with non-ST elevation MI or unstable angina who are not having angiography within the next 24 hours. If a patient who present to you with non-ST elevation MI or unstable angina and he's going to undergo angiography within next 24 hours, then instead of low molecular weight heparin, we need to give unfractioned heparin. So patient present to you with non-ST elevation MI or unstable angina, aspirin, oxygen, morphine, nitrates, And low molecular weight heparin if he is not undergoing angiography within next 24 hours, or unfractionated heparin if he's to undergo angiography in next 24 hours. So low molecular weight heparin if no angiography within next 24 hours, and if there's going to be angiography within next 24 hours, then unfractionated heparin. What is another indication for unfractionated heparin in patient with non-ST elevation MI or unstable angina? The other indication is that if the patient's creatinine is more than 265, or patient is in renal failure, then low molecular weight heparin is also contraindicated. In this case, you will also give fractionated heparin. So again, a short summary in the management of non-aspiration and unstable angina is that aspirin 300 milligram, morphine for pain, or nitrates can also be given to relieve pain. Now we are going to decide about if we need to give low molecular weight heparin or unfractionated heparin. Low molecular weight heparin will be given if the patient is not undergoing angiography within the next 24 hours. And if he is undergoing angiography within next 24 hours, then unfractionated heparin will be given. Also, if there is renal failure, then unfractionated heparin will be given. Now, the patient is admitted with non-ST elevation MI or unstable angina. Now you need to calculate his 6-month predicted 6-month mortality. Remember that if patient with unstable angina or non-ST elevation MI is clinically unstable, then he should undergo angiography as soon as possible. And if patient with unstable angina or non-ST elevation MI and his 6-month predicted mortality is above 3%, then he should undergo angiography within 72 hours.
Can
And
you
if the
repeat that?
patient is clinically,
Can you repeat
yes,
that?
yes, I'll repeat it. First, there's a third scenario. If the patient with unstable angina or non-ST elevation MI is clinically stable, then he can be managed conservatively. So we have three scenarios. First one is that patient with unstable angina or non-ST elevation MI is clinically unstable. He should undergo angiography as soon as possible. Second scenario is that patient with unstable angina or non-ST elevation MI have a 6-month predicted mortality above 3%. 6-month predicted mortality above 3%, he should undergo angiography within 72 hours after hospital admission. And if the patient is clinically stable, then he can be managed conservatively. Is it clear now?
Yes, thank you. And this is for the non-STMI elevation.
Yes, for ST elevation MI, PCA is done if the patient present to you within
24
12
hours.
hours of the onset of the symptoms.
12 hours.
Primary PCA is done. Primary PCA means he's taken to the cath lab directly. Means angiography is performed in an emergency.
Sir, what was the third scenario? Last
Third
one.
scenario is that if the patient is low risk, If 6-month predicted mortality is less than 3%, then he can be managed conservatively. This is the third scenario. A low risk patient can be treated conservatively. What are low risk patients? Whose 6-month predicted mortality is less than 3%. So this was all about the diagnosis and management of acute coronary syndrome. There's one additional point about the persons who are to undergo coronary angiography within 72 hours of hospital admission. They need to receive intravenous glycoprotein 2B or 3A receptor antagonist, such as eptifibatide or tirofiban, along with low molecular weight heparin to prevent complication during angiography. Now, long-term medication or long-term management, this was all about acute management of MI. Now, what are the drugs that is used for the long-term management of MI? Aspirin 75 mg is given for life, and a second antiplatelet drug such as ticagrelor or prasugrel or clopidogrel is given for 12 months. Beta blockers and ACE inhibitors, remember that tachycardia is a compensatory response during an MI, but tachycardia will lead to stress on heart, and it will increase the workload of heart. So beta blocker also need to be given for 12 months. ACE inhibitors such as captopril, enalapril, or ramipril will also be given for life. And statins, torvastatin 80 milligram is the recommended dose. This will also be given for life. So 3 medication are given for life in the management of or to the patient of who has an episode of MI: aspirin, ACE inhibitors, and statins. These 3 drugs are given for life, and 2 drugs will be given for 12 months. Which are those 2 drugs? Ticagrelor or beta blockers. So remember these 5 drugs which are required for the long-term management of MI. 3 of them are given for life and 2 of them are given for 12 months. So this was all about the short-term management of MI and long-term management of MI. Is it clear to everyone? Is there any question? Anyone want to ask?
Yes, I have a question.
Yes.
Okay. When we will do immediately angioplasty, that is unstable, am I right? But if the patient is stable, then we will try to give drugs. I mean, which drug we will give first, heparin or aspirin first?
Both of them will be given simultaneously.
Okay.
Aspirin
Okay.
300 mg to all the
Mhm.
patients. Then if the patient is non-ST elevation MI or unstable angina, then low molecular weight heparin.
Okay. When we give Honda, not heparin?
If the patient is not undergoing angiography within the next 24 hours, and if the patient renal functions are normal, then low molecular weight heparin will be our choice. And if he has
Okay.
to undergo
Mm.
angiography within next 24 hours, his renal
Okay.
functions are not normal, his creatinine is raised 265. If his creatinine is more than 265, or if he is to undergo angiography within next 24 hours, then unfractioned heparin will be given.
Acha. Why we will do within 24 hours angiogram? This thing will be written in the question paper that this patient will go and angiogram within
Yes,
24 hours.
yes,
Okay.
yes.
Okay. What are
Uh,
those
Sir,
conditions?
there is two type of patients need to undergo angiography within 24 hours, and one are those who are clinically unstable,
Okay.
and the second one are those in which there is widespread ST elevation on ECG,
Mm.
plus widespread ST depression in all the leads, plus ST elevation in
Okay. Those
AVR.
patients we will need angiogram within
They need to
24 hours.
undergo,
Oh,
yes.
okay.
sir, example. Yes,
Anyone
sir.
else?
Sir, example of unfractionated heparin is fondaparinux.
Unfractioned heparin is basically heparin. Fondaparinux is a low molecular weight heparin.
Okay.
Unfractioned heparin is a larger molecule with a high molecular weight. And unfractioned heparin is fractionated or break down to form low molecular weight heparin such as fondaparinux and the other ones,
Okay.
enoxaparin, etc. Any more questions? So can anyone tell me what are the long-term medication for the patient of stroke?
Sir, it's clopidogrel, and along with
Clopidogrel
it,
for how much duration?
clopidogrel for 3 months
Dr. Shafraz, can you confirm the
plus
duration of
statin
clopidogrel?
for life, I think.
Isn't it for life? You start with aspirin
Yes,
Yes.
first for 2 weeks,
Steady
and then
state
you
of-
go to clopidogrel.
yes, aspirin 300 mg for 2 weeks, and then
Yeah,
clopidogrel for life. While in case of MI, aspirin for life and clopidogrel or ticagrelor is our choice. Ticagrelor or prasugrel is our choice in case of MI. But
that's
if
for
there is
12 months,
increased,
right?
yes, for 12 months. But if there is increased risk of bleeding, such as patients who are already taking anticoagulants such as warfarin or direct-acting apixaban, then clopidogrel will be used. Otherwise,
Sorry, could you repeat that again?
our first choice for the long-term management for the second antiplatelet drug in the management of MI is ticagrelor or prasugrel because they are more effective than clopidogrel, but they have an increased risk of bleeding. So if there's a risk of increased bleeding, such as in patients who are already taking anticoagulant drugs, warfarin or direct-acting anticoagulant, apixaban or rivaroxaban, then in those patients, clopidogrel will be our choice. So aspirin for life, ticagrelor or prasugrel for 12 months, And if the patient is already taking an anticoagulant, then clopidogrel for 12 months. Because with ticagrelor and prasugrel, the risk of bleeding is higher.
How do you spell that? Grill and the other one you said just now. So
Ticagrelor.
mentioned something about P, it starts with P. Oh, okay. Tikka grill or okay, that's fine. Tikka grill.
So ticagrelor or prasugrel along with beta blockers for 12 months, aspirin, ACE inhibitors, and statins for life. Any more questions? So if ECG shows widespread ST repression and ST elevation in AVR, then the vessel that is occluded is most likely left main coronary artery, and such patients need to undergo emergency coronary angiography, as well as those who are clinically unstable. They also need to undergo emergency coronary angiography. Now we are going to discuss some complications of myocardial infarction. What are the immediate complications and what are the long-term complications of MI? Now, there are two immediate complications of MI that can occur within minutes to hours or within 24 hours after MI. And those complications include tachyarrhythmias such as ventricular fibrillation or ventricular tachycardia. And the second one is acute decompensated heart failure. So the immediate complication of MI, there are two immediate complications of MI. One is tachyarrhythmia such as ventricular fibrillation or ventricular tachycardia. And the other one is acute decompensated heart failure. We are going to discuss their diagnosis and management one by one. So the most common cause of death in a patient of MI is ventricular fibrillation. Patient ventricular tachycardia, which can be converted into ventricular fibrillation and which can lead to cardiac arrest. So the most remember that any arrhythmia, any type of arrhythmia, either it is ventricular tachycardia or it is atrial fibrillation or whatever the type of arrhythmia, if the patient is clinically unstable, then you will select DC cardioversion or cardioversion as the management option for the treatment of an arrhythmia in an unstable patient or clinically unstable patient. Our choice will be cardioversion. While stable arrhythmias are managed pharmacologically. So how we are going to diagnose ventricular fibrillation or ventricular tachycardia following an MI? Now look at this diagram. This is an ECG of ventricular tachycardia. Let me zoom it a little bit so that now ventricular tachycardia is basically a broad complexus tachycardia. You can see in this diagram that the QRS complexes are very broad. So if ECG is showing a broad complexus tachycardia, then our diagnosis will be ventricular tachycardia. While in case of ventricular fibrillation, as you can see in this diagram, there's a bizarre pattern and no waves can be identified in this ECG. In this ECG, you can see that there is no identifiable wave present. There's this wave, then there's this wave, then there's this wave, then there's this wave, but you cannot tell that which waves are those. If broad complexes are present on ECG, then it is ventricular tachycardia, and if there is no identifiable wave on ECG, then it is ventricular fibrillation. So ventricular tachycardia or ventricular fibrillation can develop after MI immediately or within 24 hours after MI they can occur. How we are going to manage ventricular fibrillation and ventricular tachycardia? If ECG is showing broad complexes and the patient is conscious or semi-conscious and is hemodynamically stable, then we will manage ventricular tachycardia by giving him a myodrone. So ventricular tachycardia